All right, so the waveform. So what can we get from the waveform here? So the tracing is going to then, of course, is coming from the cable. It's going to come from the mechanical signal from the patient into the cable, into our monitor, and we're going to get a nice little tracing on our monitor there, right? So the heart function can be gathered from this. Again, if we said if that upstroke is very, very weak, right? Instead of being upright like this, it's super, the slope is a little bit depressed like that, right? So comparing a slope right here can tell you how good the heart is functioning. It could also be aortic stenosis, like we mentioned. If they have aortic stenosis, it's going to be really, really difficult to get that fluid out or that volume out as efficiently as if they did not have aortic stenosis, right? So aortic valve function and also hemodynamics. So fancier monitors can actually use some calculus and calculate the volume under the curve, right? Or the area under the curve. So they can calculate how much volume is there during systole, how much volume is there during diastole on the other half, and you can get a map out of it. You can get a cardiac output out of it as well. The area under the curve times heart rate, right? Stroke volume times heart rate, that is cardiac output. So they just take that little piece right there. They can measure where the dichrotic notch is. This little notch right here. It's kind of our ballpark of where systole ends, right? And it used to be thought that the dichrotic notch was the closure of the aortic valve. As the aortic valve closed, it kind of reciprocated through the system, and you could pick it up on your monitor. That's a complete lie. That's not what it's for at all. So it's actually a reflection of the periphery's vasoconstriction. So as this blood hits the periphery, right? I think I have another slide that illustrates this, but as you pump all that blood into the system, it's going to then reflect onto the vasoconstricted wall. If that's a huge wall, that's going to reflect much higher up this dichrotic limb here. Compared to if they're really, really vasodilated, it's going to take a while for it to hit that, hit a wall and then bounce back at you. So this dichrotic notch here can be variable based on your afterload, or your SVR, I should say, right? So it's from peripheral vascular resistance is what changes the location of that dichrotic notch. Yeah, there's an anacrotic limb. That means when it's going up, and dichrotic when it's going down. And then a systole lasts until, of course, the closure of the valve. We can estimate where it's going to close, right? Somewhere on that area. And again, this is our systolic or stroke volume there, and that the rest of it is your diastolic blood pressure. And then we can calculate a map from it, right? So area under the curve times heart rate is your cardiac output if we're just doing it just the systolic portion. Right, diastole lasts from the dichrotic notch approximately to when systole begins again, right? And systole technically begins just before this section right there. When we talk about balloon pumps, it's really important that we deflate the balloon before the heart opens up and hits a balloon, right? We want to make sure that we are closing the balloon. We don't have some malfunctions there. We have definitely some chest pain for sure. So you can see here this aortic valve as it closes. Yeah, that's nice and it makes sense, but it's really a reflection of the periphery. And if you look at someone who's like a really, really severe shock, you're going to see the dichrotic notch all the way down at the base, right? When you have someone that's really, really vasoconstricted, you're going to see the dichrotic notch higher up. So it tells you an idea of what their SVR is. Okay, so aortic valve issues. So we kind of talk about aortic regurg, aortic stenosis. So we're kind of recapping here. All right, so aortic stenosis is when your valve is not opening all the way, and we have this stenosis occurring, this blockage occurring, right? So it's difficult to get this blood out into the aorta, right? So since it's difficult, you're going to see the slope of this limb instead of being upright, it's downright, right? Or it is slanted more than it should, right? So that's a sign of aortic stenosis. And we can't get a lot of blood out. We can't really get all the stroke volume we would like. So the height is also decreased. So when compared to where it was to where it is, it's going to be reduced, right? And then the body's going to say, what the heck? Where's all my stroke volume at? Where's my systolic blood pressure? And what is it going to do when it doesn't get the blood pressure it needs? It's going to vasoconstrict. So it's actually going to raise the diastolic blood pressure. So it's going to go up compared to where it was before, right? So that's going to do what to the difference between the systolic and diastolic? It's going to make it more narrow, right? So that's called pulse pressure, right? So the pulse pressure will be changed when you have a aortic stenosis, for instance, right? I think the next slide describes pulse pressure. All right, so the pulse pressure gets very, very narrow with aortic stenosis. It also gets narrow with like a really bad CHF, right? CHF is almost the same thing. We're not able to pump out a lot of blood, and therefore the systolic blood pressure is lower amplitude, and therefore the body is going to respond by vasoconstricting, and that's not going to help out the heart, but we can see a narrowed pulse pressure in CHF, for instance. Okay, the slope is slurred, the systolic peak is lower, the pulse pressure is more narrow because the SNS is going to start kicking in. Okay, the dichrotic notch is less pronounced, right? Because they're not really, before you're hitting the periphery with 100 cc's of blood, right? And now you're hitting the periphery with like 50 cc's because you're not putting a lot of blood. So you're going to see a less pronounced dichrotic notch, right? If you don't treat it and they have severe aortic stenosis, you can see like a unique waveform where it looks like you have almost like two impulses happening. It's a little bifid waveform. So that's, but usually they get this fixed before they see it because it's going to hit the periphery late, and it's almost disassociated. It looks like they're almost separated, right? And then it's shifting gears to aortic regurg, right? Aortic regurg, it's super easy to get the blood out. There's no problem getting blood out. The problem is that the blood falls right back in where it came from, right? So it's easy to get the blood out, right? So blood goes out whoosh, super easy, right? Aortic regurg, the blood goes out super easy right here, right? It hits the periphery. It might bounce back, but we're definitely going to fall back into the left ventricle before that happens, and we're going to then bounce back. Right, while that valve is still open, you're going to see this characteristic double peak on the A line, and then the reflection from the periphery will then bounce back, and we'll get our little dichrotic notch, right? So what's the pulse pressure going to be? Well, it's super easy to get the blood out. It's going to be a great systolic blood pressure. And then what's the diastole is going to be, I mean, you pumped all 100 cc's of blood out of the heart, and it's going to then go right in the periphery right away, right? And their diastolic blood pressure is actually going to be a little bit on the lower side, so you're going to see a wide pulse pressure, if not just for the reason why you have a great systolic. Okay, so the pulse pressure is wide. And then the dichrotic notch is a little bit less pronounced because you don't have much to reflect in the periphery in the first place, right? And if you have severe aortic regurg, like we'll see this little bifid waveform. All right, so you can see how this is nice and upright here compared to this one, which is more difficult to get the blood out of the heart. So aortic stenosis has that fallen over effect. CHF also looks like that really bad CHF, so the really bad EF. We'll have that characteristic fallen over that slope. That slope won't be nice and up and down and straight like a normal waveform. It'll be actually fallen over. Okay. And we mentioned with SVR, that's kind of the similar concept, right? If you're vasoconstricted, it's going to be very difficult to get that 100 cc's flowing into the periphery. It's going to be really, really hard to squeeze it, right? It's going to be backed up like Disneyland, right? So it's all backed up. You're going to have a wider width of our waveform compared to if everything's open, right? You're going to go right into the ride, right? So you're going to go straight on through, and there's going to be no wait, right? It's going to be super easy to get the blood out, hopefully, and then it's going to be super easy to get the blood through into the periphery. Okay, and if you notice the reflection in the periphery, since it's super easy, it's going to be a while until it hits a wall, right? Until it hits vasoconstriction, if it even does. So you see the dichrotic notch is much lower compared to a normal waveform, right? And then same thing if they are vasoconstricted. Very vasoconstricted, it's going to hit that wall really quick, right? And it's going to bounce back really quick, and you're going to get a dichrotic notch that's higher up that limb. All right, so pulse pressure, a little bit of note on pulse pressure. So that's your systolic minus your diastolic. It can tell you a lot of information whether your patient is vasodilated or vasoconstricted. Just right off the bat, you can say, oh shoot, that pulse pressure is super wide, right? That means, you know, in the ICU probably means their diastolic's in the toilet, or because they're vasodilated. They have septic shock or distributed shock of some sort, right? So they have a really wide pulse pressure, like 100 over 20, or they have like, let's say 140 over 40. That's a huge pulse pressure, right? So systolic minus your diastolic. Normal is about 40 to 60-ish. If you think of 120 over 80 or 90 over 60, has a 30 to 40 points of difference. Why would you have a wide pulse pressure greater than 100, right? So we have a distributive shock, a vasodilatory shock of some sort, and we'll talk about shocks coming up in our coming lectures, but that's when you have a drop in your diastolic blood pressure, because diastolic blood pressure is a function of how vasoconstricted you are. If you're super vasodilated, you're going to have a lower diastolic blood pressure, right? And with age, obesity, inflammation, All these things lead to a rise in my systolic blood pressure, right? So with age, I get arteriosclerosis, right? They get hardened. On the previous slide, I think I didn't point it out, but you have that aorta needs to stretch and accommodate that stroke volume. If it can't stretch, that's going to be a really, really high systolic blood pressure because that's the pressure that's measured during ventricular systole, right? So we're going to have a high systolic pressure. Obesity does it because of inflammation, and hyperthyroid is just too much SNS activity. So you're going to have a really high pulse pressure in these situations. Aortic regurg we mentioned because there's no diastolic ceiling. There's nothing stopping it. All the blood goes out, and then it's done, right? So you're gonna have a really wide pulse pressure in this situation. In bradycardias, you can see a bradycardia here. You got plenty of time to fill, plenty of time to push out a lot of blood if you needed to. So you're gonna have a wider pulse pressure with bradycardias. And you can just think of tachycardias as SNS and the vasoconstriction happening. That's gonna definitely raise up my pulse pressure, or narrow my pulse pressure. So bradycardia causes wide pulse pressure, tachycardia causes lower pulse pressure. So in red here, these are reasons for wide pulse pressure, and in blue are the reasons for narrowed pulse pressure, a pulse pressure like less than 40. And just of note is when you have a pulse pressure that's wide, it puts you at high risk for AFib. So it's not something just to take lightly. It's like, oh, you got wide pulse pressure. It puts you at risk for AFib, and then it's unknown, and they can develop embolic strokes and such. All right, so why would you have a narrow pulse pressure? Well, you're vasoconstricted. That's going to raise up this bottom number, right? So where's my at here? So instead of being down here, if the diastolic blood pressure is here, it's going to go up a little bit, right? We're going to squeeze and raise our diastolic blood pressure by vasoconstricting, right? And so another piece besides vasoconstricting, and it does also happen when you have CHF. When you have CHF, you're not putting out a lot of volume. And then the body's going to respond and say, hey, there's not a lot of volume out here. I'm going to vasoconstrict. So that will raise it from the bottom. And the top will actually fall down, just like we talked about with aortic stenosis, because we're not putting out a lot of blood, right? We had a poor cardiac output in the first place. Our systolic blood pressure is not going to be that impressive, okay? And then tachycardia we talked about, there's less filling. We're not going to put out a lot of blood either, right? So we're going to have a narrowed pulse pressure in that situation. Volume loss, you're losing volume. You're going to have a narrow pulse pressure because, again, you heard not stroke volume. What's the components of stroke volume again? Heart rate, contractility, and this one, which is preload, right? So your preload is going to be poor when you have hypovolemia or hypovolemic shock even. So you're not going to be pushing a lot of blood out to stretch that aorta, right? That aorta gets stretched when your heart contracts, right? It's not going to stretch a lot when you have CHF. It's not going to stretch a lot when you have tachycardia because you can't fill up with a lot of preload. And also when you have poor preload because of hypovolemic shock, it's not going to be that wide, that different. So looking at pulse pressure, I can tell you which shock you have. So if you have septic shock, which is vasodilatory, that's going to be a wide or narrow pulse pressure. It's going to be a wide pulse pressure because diastolic blood pressure is a function of vasodilation, right? The more vasodilation, you have less diastolic blood pressure, right? So it'll be like 120 over 40, let's say. Whereas if you have hypovolemic shock, that's not going to be 120 anymore. You're only going to be able to hit 100 because your stroke volume is poor. And what's your body going to do to compensate? It's going to start to vasoconstrict the other end. So you're going to have like 100 over 80 or something, 100 over 76, right? So that's pulse pressure like 24. So you can tell the difference between the shock. So, oh, I can't know if you give fluids or should give more pressors. Like, well, shoot, they're vasodilated, give pressors, right? Giving fluids is just going to fill up a cavern or a dam. It's not going to do much, right? Whereas if they're very, very poor in volume, then yeah, giving more volume can help out in this situation. All right, and then tamponade is a worst case scenario. We got some tamponade happening. We're not able to pump out blood because we're literally squeezing the heart and it's filling up with fluid around it. You can't pump out a lot of blood, right? You can't pump a lot of blood. That's just like, what the heck? Where's my blood at? And it's going to start squeezing down, and that's going to cause a narrowed pulse pressure. So which triad? Cushing's is more for ICP. So ICP has the, ICP, it's more going to be, this isn't really pulse pressure changes, it's more change in your, your heart rate variability. So you can start getting heart rate changes all over the place. Beck's triad is for cardiac tamponade, right? That's where you have the muffled heart sounds, you have low blood pressure, and you're going to have what kind of pulse pressure? Wide or narrow? Narrow pulse pressure, and of course you have JVD as well. All right, so pulse pressure variance. So this is something we can do on our monitors. We can pull up on our monitor screen there. It's called SPV, unfortunately. I'm not sure why it's called SPV when it should be PPV. That's what everybody calls it. But then GE monitors call it SPV, or stroke volume variance, or stroke, I don't even know what they would call it. Stroke something. Anyways, they have a pulse pressure variance. You're looking at this difference in the top and the bottom of our waveforms, right? And normally, when you are putting positive pressure in the chest with like a ventilator, you're going to be squeezing like a sponge all that blood into the left atrium. That's great, and that means for that inspiratory cycle, you're going to have a little extra blood pressure. So you're going to have this little variation in your pulse pressure. That is a normal finding. And if it's a big finding, right, then that like it's a greater than 12%, right? I think it's like about 10 to 12 points or so. Then that's a sign that you might be responsive to fluids. They might be a deficit of fluids. Okay, but there again has to be 3 criteria met. They have to be on the ventilator. They have to be in a volume control mode, a pressure control mode. They have to have like about 8 mLs per kilo if they were in a pressure control mode. And they can't have an open chest because that's going to be, now your pressure is being lost in the open chest, right? They have like a chest tube in place, or they had cardiac surgery or something like that. So it's useful in that it can measure if you have a fluid deficit or not, or a preload debt, let's say, right? So if you imagine if you're like getting a paycheck, right, and you spend the paycheck, right, and then now you're in debt. So you're going to see a lot of swings in your bank account compared to if you budgeted correctly, which I don't, right? So that'd be something that you would be able to identify, right? You can see that the pulse pressure variance is going up because, the RV is behind. It's not getting a lot of fluid to deliver to the lungs, right? So the RV delivers its fluid, and then all that fluid gets squeezed in the left atrium for the inspiratory cycle. It's like, wait, where's my fluid at? And their RV's like, I'm only getting $10 an hour. I can't give you much more on the next cycle. So you're going to see this variance between the cycles because of that. So you can do that on our GE monitor, and it can measure exactly how much pulse pressure variance you have, right? The other red flag is if you see a drop in your blood pressure during inspiration. That's a sign of cardiac tamponade. That's not good. You should see a little bit of a rise in your arterial line tracing during inspiration, but if inspiration is causing a positive pressure on the chest and it's compressing the heart, and you get less flow because of that, that is a sign of tamponade. So that is not good. So it's something to be alert to see what the variations are. Okay, so tamponade can cause a drop in your pressures during inspiration, whereas when you just have a normal physiological variance, you're going to have this little widening. You're going to have a little widening and narrowing during inspiration, narrowing during expiration. And if it's a super widening, right, more than 12%, right, that's a very big change between point A and point B, more than 10 points or more than 12%, that's considered someone that might benefit from fluids. They have a preload deficit. They're in preload debt. Okay, so other abnormalities. So we have ectopy. It's easy to see if someone has ectopy on the A line. You can see an extra little, they got little PVCs going on there. You see an extra, maybe a little jolt of blood go, or less blood be ejected because PVCs are not expected, right? We want to go through the normal cardiac cycle and get our normal stroke volume. A lot of PVCs can, of course, result in VTAC and poor flow. LV failure, as we mentioned, you're going to have a lot of, you're going to have really poor output, right? So if you have someone who's really severe CHF, they're going to have a blood pressure that is very, probably might be on the low side if they get heading towards cardiogenic shock, but you're going to see like a very, very small, weak amplitude, right? Decreased stroke volume and increased resistance because of someone going into CHF, right? Their pulse pressure will be narrow or wide if they have a poor systolic blood pressure and a body that responds with SNS vasoconstriction. It's going to be narrow, right? And then we have someone who's hyperdynamic. So hyperdynamic, not ADHD, but someone that is going to be contracting the ventricle like nobody's business. That can happen in early sepsis, really severe infection early. And that can be something, what's called a high output state, right? That can happen, yes, early sepsis. It can also happen in someone who's hyperthyroid, right, which is just too much SNS activity. Too much SNS activity on the beta-1 receptors of the heart makes more heart rate and also more contractility, right? If someone's anemic, they are, hemoglobin's like 6, 7, 5 even, they are it's technically hypoxic, right? They're not delivering a lot of O2 to the body, so the body's going to respond to that hypoxia by increasing SNS activity. So you'll see in anemic patients, all right, a really severe GI bleed or a really severe anemic patient, you're going to see a really, really hyperdynamic cardiac output. They're going to be squeezed as much blood out as they can. Okay, so increased systolic blood pressure can also, with like too much fluid in the early, can cause a hyperdynamic circulation, but most commonly it's like an anemic patient or early sepsis patient that we would see this in. Right? Weak amplitude, like we said with CHF, or if someone has what valve disease, aortic stenosis or aortic regurg, would you have a weak amplitude? Stenosis, right? Stenosis, you're going to have this fallen over effect, right? Compared to aortic regurg, which is nice and upright, right? It's super easy to get the blood out. Whereas aortic stenosis, it's not easy to get the blood out. There's a stenotic valve in the way, right? So that's the idea behind these, by the A-line waveform. It can tell you about valve disease, it can tell you about someone's CHF, it can tell you about their, of course, your pulse pressure. Yeah, you can get pulse pressure from your NIBP, but you can't get it, beat to beat and know if there's variance or not. See if they have tamponade or something to that effect, right? It can tell you what kind of shock they have, whether they need fluids or not, or they need pressors. So you get a lot of information from this, right? And you can see this paradoxical pulse that you see with inspiration. As you inspire, you're putting more positive pressure in the chest on someone on the ventilator, and it starts plummeting. That's a sign of cardiac tamponade, of course, which is not good, right? What else on this? So we'll talk about some of the electrical activity that happens with tamponade coming up, but basically this is what you're going to see on arterial line tracing that is useful. All right, so how do you know your A-line's accurate? You can do the square wave test. So a square wave test is where you're determining if it's done, if you're getting good readings on your monitor, right? So we're doing a quick little square waveform test here, and there's a few different outcomes that can happen. So the goal is when you pull the little pigtail on the side right here that you use to flush your catheter, you're going to pull it, and it's going to deliver 300 millimeters of mercury of fluid into the patient, right? And you should be able to see that 300 millimeters of mercury. And then you let go, right? And then it should bounce as everything kind of equilibrates, right? So it should bounce when you let go, and there should be about 1 to 2 bounces. They technically say 1.5, but I'm not sure who's counting 1.5, right? So 2 bounces is it, and that's it. If it like comes down like super slow, so it comes like then just 1 little half bounce, that is something that means there's probably a difficult getting fluid into the patient, or they have an occlusion of some sort. There's something going on that's blocking the flow of that fluid, right? The catheter could be kinked, but we do have we have tubing that is hardened, so that doesn't happen, but it can happen, right? So that's a dampened waveform. When we have less than 2 bounces, right? Less than 2 bounces, you got a slow return to baseline. It takes a long time to get down to the bottom there, right? They might be positional. Their arterial lines very positional, so it only works when their hand is extended. When they start moving their arm inward and flexed, then for radial artery access, then it can be very, very dampened, just based on the catheter kinking inside the skin. And there's little tricks out there to make sure it doesn't kink. You can like fold this little gauze here and kind of get it at the angle it needs to be put in, or the angle was originally put in, because your catheter should be going at an angle. It should not be like flush with the skin and taped down. It should be going at a little bit of like a 10 to 20 degree angle. So we can make sure it's secure, and we can have to get the arm boards to make sure that we have good adequate anatomic position. That can cause a dampened waveform, right? And how you know you have a dampened waveform, just by looking at it, you can see your waveform looks like just like a little hump, little hill in the valley, right? It's like, well, do they have like severe CHF and narrow pulse pressures, or do they have a dampened waveform, right? So we can lose that dichrotic notch that should be there because we're not getting an adequate reflection of what's going on. There could be bubbles in the line, which is the most common. That's why we do what? Wet to wet, dry to dry, dry to wet, wet to dry. Which one? Wet to wet, right? And then there could be clots in the line. Somebody didn't flush it adequately. So we want to make sure that that's why it's always flushing. Your bag is inflated, right? Your bag's deflated like this, where I don't see the green. Then that means it's putting less pressure on the system, right? So it's putting like 120, and their blood pressure is 110. That's not going to be, there's not a lot of difference there, right? So you're going to be seeing a dampened waveform. Loose connections, that's bad, right? So if that's like the loose, more and more loose, more and loose, more loose, and then of course if it disconnects, that's an issue. But it could be loose connections as well that could cause a dampened waveform. And how do you fix it? You fix the stuff above. Don't get bubbles. Make sure you have good positioning. Make sure you're flushed all the time. Make sure you have a good waveform when you're doing blood draws, for instance, right? An arm board can help as well, maintain that angle of attack. And then what about underdampened, right? So, or a hyperdynamic waveform. So a waveform that is very, very jittery. It's going to be going up and down, up and down. You can probably see little other jitters on the waveform as well. Basically, when you do the square waveform test, you're going to see a lot of impulses there, right? So when you let go, you're definitely going to see more than 2 bounces. So how many bounces we got here? We got 1, 2, 3, 4, 5.5 bounces, right? So 1 bounce equals a below and above, FY, right? So we got a, how many it should be how many bounces for a normal waveform? 1.5 to 2, right? So 2 bounces and that's it, and you're done. And you come back to normal, right? So this, for instance, is 1 to 2 bounces. This is an optimally dampened waveform. Whereas if it's underdampened, or means it's not, that means it's not dampened. That means that it's very, very volatile and to changes, right? So we might see a lot of artifact on that limb, like over here. We see all this extra stuff on the waveform. What causes this? Tachycardia can do it. A lot of air can cause it, right? So the large bubbles, they might, like little small bubbles, get in the way and cause dampened waveform, but a lot of bubbles can cause a hyperdynamic waveform as it rattles through the tubing. Vasoconstriction can do it, as we're really vasoconstricted. The catheter inside the artery here, so here's our artery, and here's my catheter sitting inside. If I'm vasoconstricted, I can have this catheter bouncing around on that artery. So if someone's very vasoconstricted, they can be hyperdynamic. They can have very underdampened waveform. And then what else? So catheter size. If I have really too big of a catheter, it's the same situation, right? The catheter is going to be bouncing against that artery when it shouldn't be. Okay. And if you notice here, the values are accurate, of course, when you have an adequately dampened waveform, or a waveform that has how many bounces? 1 to 2, right? Then we have a great waveform. Systolic's great, diastolic's great, MAP's great, right? When I have a dampened waveform, I'm not going to get a great systole, probably not a great diastole. And look at the map though, accurate, right? Why is the map accurate? Because you're measuring the area under the curve here. And the area under the curve does not change whether you are dampened or you are normal. Same thing if you have an over-dampened system, right? Sorry, I said under-dampened, but it's still the same, right? The map is still accurate in all 3 situations. So this is why you should always titrate to MAPs and not systolics, because a systolic can be overshoot when you have a hyperdynamic waveform. It's like, oh shoot, your systole is 140, but it's not really 140, right? You look at the map is going to be accurate every single time. So even if your system is not, is underdampened or overdampened, your map is always accurate, right? So that's why we should be titrating to MAPs and not systolics. Okay, so this waveform in the middle right here, what does this one look like? Is that dampened, overdampened, or hyperdynamic? So it is, yes, overdampened there. But yes, if there is less than how many bounces? Less than 2 bounces, right? So this guy down on the bottom here, bottom right, this guy is definitely more than 2 bounces, right? So we got 1, 2, 2.5 bounces. I mean, that's not something to write home about. But if I definitely have more than 2 bounces, I'm going to be underdampened or overdampened. Underdampened or hyperdynamic. And so it doesn't make sense when you say underdampened. So you got overdampened, I'm too much damp. I'm making it too occluded, or I'm dampening it. I'm turning down the volume. Whereas I under volume it, or what, that doesn't make sense, right? It's hyperdynamic or too much volume. Okay. So A-lines and their waveforms and their reflection of the waveforms. So every site that you put you transduce for arterial lines, you put in the radial, it has a specific waveform. You put in the dorsalis pedis, has a certain waveform. You put in the aorta, has a certain waveform. Axillary has a certain waveform. And it just depends where it's at, but the goal here is that the map is still going to be accurate every single time. And the other piece is that your systole and diastole and your map, yes, it will be accurate every time depending on whether it's dampened or underdampened, but now we're talking about is, if I have a radial artery, is that the same as the pressure in my chest? And the answer is no, it's different, right? Because we actually are reflecting the impulses from the chest. So here's my heart right here, pumping blood, right? Here I've got a little A-line waveform. It's going to be reflected and refracted and echoed and get louder as it gets to the periphery. So you notice the dorsalis pedis all the way in the foot is a much, much higher systole. And the map will actually be a little bit higher too. And then same thing with radial. The radial map of 65, it could be actually a map of 55 in the coronaries, right? So that's why we always say, map of 65, to kind of overestimate so that we are, we don't get too low. Because you say map of 60, it could be even down to 55 to 50 map that we are actually getting centrally, right? So we can see here is our radial artery, right? Is this guy right here. There's our dorsalis pedis all the way up there, and here's our femoral down here. Where's our actual aorta? Our aortic artery might be somewhere like this, right? So our aortic tracing will get reflected into the femoral just a little bit because it just goes right there, whereas it reflects to the radial, it's going to be a much higher value, right? So that's a key thing to think about when you have A-line tracing, is that it is not truly what their blood pressure is. You might want to even target a little bit higher if you need to. If you're seeing symptoms, right? You're seeing like acute kidney injury developing, it's because you're reflecting it. Okay, so peripheral catheters are reflected due to this resistance that's being developed. The more resistance there is, the higher the waveform will be. Just like on the previous slide, we get hyperdynamic waveforms when the more vasoconstricted we are, right? On the previous slide, we had, you could the map is the same in that place, but comparing that map there versus the aorta, they are much different, right? Which one's higher, the aorta or the radial? The radial is higher because it's being reflected and refracted, all right, and it's being amplified as it gets bounced from the aortic waveform. It gets bounced all the way down the aorta here, and it gets bounced down the femoral. Not so, it's pretty much a straight shot, right? So it goes up a little bit, right? So we went from this to this, right? And if we go into the radius, the dorsalis pedis for sure, it's going all the way up there, but our radial is probably right there, right? So we have a reflection, we have a overestimated blood pressure. So over here you can see the aortic versus the radial, right? It makes more sense when it's overlapped. You can see here's our amplification from this point to this point. We have this change in blood pressure. Okay, so which one do I use? My NIBP or my A-line? My NIBP gives a better blood pressure, so I must use the NIBP, right? That's the one I should use. That's a better pressure. I like that. I'm going to use that one. That's the wrong thing to do. The right thing to do is always use the A-line. The A-line's always going to have an accurate map, whether you're dampened or underdampened. Someone say, oh, my A-line doesn't work. It's like, well, the map's still accurate, right? Unless it's like completely occluded off, and of course it's not working. But as long as you have a trace down there, you can trust the map, basically, okay? And it's the most accurate measure of your blood pressure. Your NIBP it's going to overestimate your blood pressure as you get lower pressures here. So you see here's the actual arterial blood pressure, and then here is what your NIBP is actually estimating it to be. So it overestimates it. So of course it gets telling you 90 over 60, but your blood pressure is actually like 80 over 40, right? So it's better to use the A-line in that situation. On the flip side, on the high end, you can see that it underestimates our blood pressure. So our blood pressure is actually a lot higher than it really is, right? So it's better to have a A-line when you have really high pressures and they're sick. It's better to make sure that we are, make sure that the arterial tracing is there, because we know it's the map's always accurate. It might be a little bit finicky, it might look a little dampened, hyperdynamic, but we know the map is accurate. Because if we compare that to the NIBP is like, oh, it's off by 20 points. It's because your NIBP is only as good as it is, right? It's a device that we can use and validate, but the A-line is a better device. That can always get you an accurate pressure from second to second as well, right? So remember, the systolic diastolic might be inaccurate, but the map is always accurate, right? As long as, of course, you are level, right? Make sure you still got to go through all your motions, make sure your A-line is level with your phlebostatic axis, right? NIBP, it does measure maps, right? It gets a map, and then it will estimate your systole and diastole, and it can overestimate or underestimate it based on the map that it gets from its oscillating sensors, right? And they won't tell you how it works. They got these like keep your secrets. Like we have no idea how they calculate a map. It's like they use some kind of proprietary formula. They use some formulas that leaked out, like 11 herbs and spices. But other than that, there's like GE. They have their own private formula to develop to assemble a map, right? To ascertain a map. They say, hey, this is your map. And we just got to trust it, right? Because they say, oh, we validated it, we promise. Pinky promise? Yeah, pinky promise. You validated it on 1,000 people. So okay. So for me, I kind of want to know how they got the map. We know how to get a map in school, right? Systolic times 2 times diastolic divided by 3. But you would never use this formula unless you're doing a manual cuff pressure. If you're actually listening to Korotkoff sounds, then go for it. You could go ahead and get a map off that. because Krakow sounds you're measuring systole and you're measuring diastole, whereas with a NIBP cuff, it's measuring oscillations, right? It's not measuring systole and diastole. It's not measuring the peak pressure and the lowest pressure. It's measuring flow, and it's getting a map based on that value. Okay, so you have to trust the map on the NIBP, but the systole and diastole on the NIBP you can't trust, right? That it's going to be overestimated or underestimated if you're in the extremist ends here, if you're less than 90 or more than 160. But other than that, you can trust if it's in the middle range, your NIBP. But your A-line you usually need for someone's hypotensive or hypertensive, and that's why it's better, because it's not going to overestimate, underestimate. It's going to give you a true value of what's going on. And of course, we know that's going to be amplifying the aortic pressure just a little bit, but that's the idea, is that it's much better than an NIBP, right? So hypertension, it underestimates the blood pressure. It says, hey, your blood pressure is actually 170 when it could actually be 190, right? And that could be the difference between giving medications and not giving medications, right? Especially if you have like a TNK patient, right? Do I say that every patient that gets TNK needs an A-line? No, but it's, you have patients that you do want to know second to second how hypertensive they are, how hypotensive they are. Okay, so that's the idea behind a NIBP, how it works, and versus an A-line. Okay, so again, as a recap, what it tells us, right? So it tells you systolic and diastolic, of course, but your map is going to be the one that's your go-to. That's going to tell you your second-to-second perfusion, and then therefore you can titrate pressors or vasodilators based on what you get, right? So organ perfusion is an equivalency of your map. So if your map starts getting lower, your organ perfusion is probably not that great. And then, of course, you do want to compare the NIBP, make sure that every 4 hours we are somewhat ballpark, but it's not you can't say that that's going to be a replacement from an A-line. Okay, and then coronaries, we mentioned before in what was it, in EK, like in MIs, right? So your coronaries do get a map, right? But their map is like hampered by the pressure inside the ventricles itself, right? So if the CVP is really high, your right ventricle is not going to get a lot of perfusion, because your right atrium is going to be stretched out, and the RV pressure is your diastolic blood pressure, which feeds your coronaries, right? Minus the CVP. That's your right atrial pressure, your right ventricular pressure. And then your left ventricle, or what feeds the left ventricle, and that left ventricle is all full of fluid and full of blood. It's going to be hampering the forward flow of volume to that ventricle. So it's just like when you measure ICPs and CPPs, right? So MAP is delivered to the skull, but there's a pressure that's going the other direction that we need to accommodate for. So we want to make sure we have a good diastolic blood pressure for our coronaries. All right, O2 supply, you can measure the stroke volume by measure the area under the curve. That specific monitors do it, like these little Dynamap monitors or our Cogent monitor. These guys are able to measure your cardiac output in real time, your stroke volume in real time, and your SVR in real time. Okay, and then of course we get ABGs, lactate, all kinds of fun labs, right? And then there's no difference between on like one side or the other, whether your glucose will be higher or lower. Maybe a little bit, but it's not a discernible change. And then cardiac arrest wise, we could tell if our compressions are good, right? And we could tell if we have ROSC or not based on our A-line tracing, just like our end-tidal CO2 could tell us if we have ROSC or not. All right, and the pearls to recap, want to make sure that you are keeping the site visible at all times. You're not going to cover them up and tuck them in, right? You want to like a Cuban cigar. My patient is nice tucked in. They are great, right? There's an exsanguination station otherwise if that happens. All right, make sure your monitors alarms are set. You're keeping track when the blood pressure is getting lower and lower, or if you have it for hypertensive reasons, that you're keeping track of that. All right, make sure you're assessing distally the 6 Ps. Make sure the pressure bag has pressure in it, because as the pressure goes down and down and down, what's going to happen to your A-line tracing? It's going to get dampened or underdampened. Can be like this, right? It's going to start being dampened because it's not putting as much pressure on that system. So then the system is able to, it's not able to be reflected as much as it could, right? And never inject anything into an arterial line, please. All right. And troubleshooting, you can do the square waveform test, see if you have a dampened or overdampened or hyperdampened waveform. But again, your map is still going to be your accurate assessment, right? But you can see if there's bubbles in the line, you can see if there's clots happening, you can see if it's a clear line, you can see if it's positional, we can try to fix it so we have good numbers so we can report off, right? And of course, make sure the leveling is correct so that we aren't, if our system is above the patient, what's that going to do to our numbers? Make our numbers lower. It's going to be harder for the system to bounce on the trampoline. If the patient is right here, right, my transducer is up here, right, it's going to be, has to go all the way up here and bounce on it, compared to if it was level with the patient, right? It depends what perspective we're looking at here. But anyways, yeah, so up here is just your cerebral perfusion pressure. Just noting that during CPR, you do want to have, whenever you let go for 10 seconds to check a pulse, your cerebral perfusion pressure drops dramatically. And it takes a while to get it back up to where it needs to be, around 40 to 50. All right, taking an A-line out. So we passed around the A-line, the femoral A-line. It's a 6-inch catheter compared to our sheath, which is much, much more beefy. And if you don't just pull a sheath out and call it a day, the sheath requires what device? It requires a femstop, right? So I thought I had a femstop over here. But anyways, a femstop, we talked about last time in cardiac, that's the one that needs to be, it's a whole procedure, 15-minute procedure, where you're applying good pressure for at least about 10 minutes for sure. But then, of course, we keep that pressure on for about an hour, right? Whereas, sheath removal is never done just manually, where you just do manual pressure. Nowadays, we have this guy here. So you can pass this guy around. This femstop is used for to apply good pressure, and we can see it the whole time to see if it's oozing, developing hematoma. So it's something that is a safer device. It's recommended, right? And then what else? So we have supplies. If you're going to pull a A-line out, not a sheath, you need gauze, of course. You need pressure tape, right? The good, stretchy pressure tape, foam tape. And of course, you want gloves, right? We don't want you to get HIV or Hep C or Hep B or anything. And then, of course, you use suture removals. These things are sutured in place. You ever see when not sutured in place, that's a problem, right? They need to be sutured in place so they don't just fall out and they start exsanguinating everywhere, right? So you're going to flush the catheter, make sure it's nice and flushed, and then you're going to kind of turn it off to the patient, and you're then going to go ahead and pull it when you're ready, right? And how do you know you're ready? You're applying pressure where? You're applying pressure over the insertion site or over or a little more proximal or distal. Which one would it be? Proximal, right? So proximal is closer to the patient's head, to the core, right? So you're going to apply pressure more proximally because the insertion is actually inserted, it's at an angle, right? So if we apply pressure just over the insertion site, then it can start oozing when you pull it out, right? So we want to make sure that we are applying that pressure. And also, applying pressure, of course, but making sure that it's proximal to the insertion site, right? We're going to cut the sutures off, remove any tape. That's usually the part that hurts the most, is the removal of tape. And then while applying proximal pressure, you're going to be, inspecting it, and you're going to go ahead and pull it out nice and slow, or nice and smooth, I should say. Right? Make sure you're holding pressure for at least 5 to 10 minutes. If they're coagulopathic, it's going to be a much longer period of time, maybe double that. Right? Apply a pressure dressing once you're done. Don't circumnavigate and you're not putting a cast in place. Right? You still want to leave a little space on the back of the arm so you can see skin on the back of the arm. Right? So you want to make sure that they are able to. That's pointy fingers, but you want to make sure you're able to see some skin on the back. All right. What else? Afterwards, you make sure they don't develop a hematoma. Make sure that you have good circulation, and we have we have no complications.